You are very welcome to this video. Now, this is about the new therapeutic agent, or the likely new therapeutic agent, called beta interferon. And I'm going to give you the bottom line in case you haven't got time to watch the whole video. Now, this is a phase 2 clinical trial. 101 patients were involved in this study. Small, I know, but it's a phase 2 trial. And it was placebo controlled, so we had a control group who did not get the beta interferon. And there was a difference between these two groups. In the people that got the active treatment, that got the beta interferon, there was a 79% reduction in the likelihood of developing severe complications, requiring ventilation, or dying. 79% reduction. Very impressive. The people that got the beta interferon also felt less breathless. They were likely to be discharged from hospital after 6 days, whereas the placebo group were only discharged from hospital after 9 days. The people that got the beta interferon were twice more likely to recover within 16 days. And the drug appears to be safe. So that's the bottom line of this video. Now, what this means, it doesn't mean we've got a new drug we can use tomorrow, but it means it's a remarkably promising candidate for phase 3 clinical trials. And from the data that we have, this is looking good. This is the most exciting, promising therapeutic we have had to date in terms of therapeutics. So you can skip this video now if you don't want the details. If you do want the details, I'll give you some more information on it. And it is, I would suggest you stick around. It is particularly interesting. And I'm going to do a bit of theory about the way that interferons enhance immunity as well. Now, so this drug is developed by a company called Synairgen. And the drug, when drugs are under development, they get a code name. So this one's code named SNG001. It's not a very romantic name, but it's what it is. Now, these interferons are already used in clinical practice. For example, we use it for treating multiple sclerosis. Sometimes the drug is given every 2 days an injection, other times it's given once a week. And I checked the price, it's £21.29 per injection. Now that sounds quite a lot, but actually, considering the benefit you get from it and the reduced requirement for other care, that's actually quite good. So this drug that this company are developing, I would hope it's going to be around about this price per day for maybe a 10-day course of treatment. So it's going to be affordable for most countries. So fairly promising price, which is important. Now, what is interferon beta? Well, basically, when you have a cell, let's imagine there's a cell there, and that cell becomes that cell there becomes infected with a virus. Now, what normally happens is this cell, the viral particles will reproduce inside this cell, and it will then release these viral particles just into the environment around about the cell. And these viral particles will then go on and infect the other cells, which are around about that cell. And the viral particles will get into that cell and they will start dividing and they will be released like that. So the virus kind of moves out. We have these cells around about here. So these immediate cells get infected first as the virus spreads out, and then other cells will go on and get infected as well as the virus spreads out. Now, basically, what interferon is doing is interferons are chemicals produced by a virally infected cell. So this cell here produces interferons. Let's suppose they're that triangular shape. It produces those interferons. And the infected cell, which has been stimulated to produce the interferons by the presence of the virus, releases these interferons into the environment around about the cell. And these interferons then interact with these cells here, the other cells round about them, and they can do different things. They will reduce the ability of these cells to produce new protein. So if a virus does get in, the cell can't produce new viral proteins. They will also induce these cells to destroy RNA, which is in the cell. Well, now that's good. It doesn't do the cell any good, but it's good because, remember, this is an RNA virus, so that's very promising. And it also means if these cells do become virally infected, these cells round about, these contiguous cells, if these cells do become virally infected, it greatly increases the probability that that cell will commit apoptosis. Apoptosis means cell suicide. So, for example, when you were very young, before you were born, you didn't have gaps between your fingers. You had just one hand plate. And the reason you've got gaps between your fingers now is the cells that were in this plate between your fingers committed apoptosis, leaving your fingers in the middle. So apoptosis is a well-known phenomena, cell suicide. So the interferons do all these things. Now, this is the diagram from I wrote this physiology textbook a few years ago, still available. So here we have a virally infected cell, infected with the virus here. So these are the viruses. And then this viral infected cell produces interferons. And these interferons then bind to these interferon receptors on adjacent cells. These are the adjacent cells here, around about the virally infected cell. And they have these effects on the non-virally infected cells to mean that they can't produce proteins, they can destroy RNA, and they're more likely to commit apoptosis if they are infected. So what that means, what you end up with, imagine that's the virally infected cell there, and of course you've got cells all over the body, there's billions of cells all over the place. Then what it essentially does, it's creating a bit of a firewall around about the virally infected cell of cells that are no longer able to synthesize new viral particles. Stops the virus from spreading out to the other cells of the body. So that's what interferons do. Remarkably clever. Now, this next bit is quite incredible. The COVID-19 virus has properties that interfere with the ability of virally infected cells to produce interferons. I mean, that is just mind-blowing. So the COVID-19 virus gets into a cell, it infects the cell, it reproduces, and then it also interferes with that cell's ability to produce interferons. So that cell cannot release the interferons to interfere with the viral activity in the contiguous cells. I mean, that is just amazing. It's like turning off the radar or something. It just gets into the cell and it takes away the ability of that cell to defend adjacent cells from viral replication. That is the virus we're up against here. I mean, it's an absolute scallywag of a virus. How on earth does it do that? But that's what they do. Coronaviruses, COVID-19 virus, prevents the virally infected cell producing interferons. Therefore, the virus is free to spread all over the lungs, cause massive lung inflammation, pneumonia, severe acute respiratory syndrome, and death, because the COVID-19 virus has switched off the very mechanism that is in the lungs to prevent it doing that. Quite amazing. You couldn't make this stuff up if it wasn't true. Now, getting back to the story here. So interferon beta is the type of interferon used, naturally occurring antiviral protein. So it occurs naturally, and it's a cytokine because it communicates from one cell to another. That's what a cytokine is. It interferes with viral replication in adjacent cells. Oh, now some of the beta interferon actually gets into the blood. This is interesting. So some of the beta interferon actually gets into the blood. So a lot of it's used locally just to protect local cells. But some gets into the blood, and from the blood it gets up to the brain. And in the brain, in the hypothalamus in the brain, it induces fever. So it actually gets to the brain to warn the brain that there is virally infected cells. So the hypothalamus in the brain responds by turning up the body temperature. And of course, the increase in body temperature, the fever, makes the environment for the viruses to grow in very uncomfortable, so it reduces viral replication. And also the fever stimulates the activity of the immune system. So the fever is good. It's part of the body's natural defense mechanisms, mediated partly by interferon and other cytokines. And it also contributes towards the achy muscles you get when you get a viral infection. Now, you might think that's bad, but of course that stops you exercising, and the last thing you want to do when you have a viral infection is exercise. So it's all good. You're supposed to feel sick when you've got a viral infection, and because it induces appropriate behaviour. So systemic effects as well as local effects. Induces fever along with other cytokines, activates immune cells. Local immune cells are activated as well, like natural killer cells. These are the large lymphocytes that kill virally infected cells. And other cells called macrophages, which are big cells in the tissues that are capable of eating viruses and bacteria and also coordinate further inflammatory and immune responses. So it's kind of kick-starting a lot of different immune functions within the cell. Reduces protein synthesis in adjacent cells, as we've said. Activates an enzyme to destroy RNA, further reducing protein synthesis in adjacent cells. So this interferon is really quite clever stuff. Now, you might have noticed already that we've said that the beta interferon, in fact all interferons, are proteins, big molecules. And of course we can't synthesize proteins, so how do we get it? Well, what happened in I think it was about 1980 this happened. Some scientists took the genes from humans that produce interferon, and they did something clever with it and put it into a bacteria. I think it was an E. coli. And now the E. coli produced the interferon. And it's also been put into yeast. So just the same way that yeast brew up alcohol, the yeast can now brew up interferons because they have the human interferon gene inside the yeast. It's biosynthesis, very clever. Producing what we call transgenic organisms. They've got some or genetically modified organisms that they've got some DNA from another organism, in this case a human, in them that produces the particular chemical that we're interested in. So we can brew up large amounts of it now quite cheaply, which is good. Now it stimulates many other interferon also stimulates many other interferon stimulating genes. So it does probably a couple hundred other things as well as what I've said. It's always more complicated than this. Stimulates infected cells into apoptosis, which we've said. Therefore, it's a key component of the human immune defences against viral infection. And guess who turns it off? COVID-19 turns it off, or greatly down-regulates it anyway. So that's the background about interferons to make sense of what we're talking about. So given that the COVID-19 has turned the interferons off, why not put more interferons back? And that's exactly what this therapy does. It's very simple. It is compensating for the interference of interferon activity by giving more interferon. And in this case, it's given by inhalation. So this is a phase 2 study, so a relatively small scale study. Now, this is interesting as well. This is not a scientific publication. This is a financial publication. Now, the law in the UK, or the stock market rules in the UK, require listed companies to publish the results at this stage. So they've published this to meet with legal stock market requirements rather than to publish it as a scientific paper. The scientific paper is not written yet, but it's caught everyone's attention because the results are so impressive. So this is all tentative in its sense because we are looking forward to the full scientific publication. This is essentially a financial publication to meet financial law. But let's carry on because it is remarkably interesting and promising. So this is inhaled beta interferon in a nebulizer. Now this is routine. We do this all the time. We give inhaled salbutamol, for example, or ipratropium bromide for asthma. Or we give inhaled steroids for asthma as well. So inhalation therapy is absolutely routine. Do it every day on A&E. Several times, well, a dozen times a day. It's absolutely routine. So inhaled beta interferon gives high local concentrations because, of course, it's a protein. So if you took it as a tablet, it would just be digested in the stomach. It wouldn't work. Now, it's good that this trial was placebo controlled. So about 50 patients got the beta interferon. and about 50 patients got the placebo, presumably salty water. And they were comparing the differences between the two groups. That's where we got those differences from that we quoted at the start. So that's good. So it's placebo. So this is the experimental group, and this is the placebo group that's the control. So it's placebo controlled, which is very good. This is how we should do research. All patients who entered the study tested positive for SARS coronavirus 2, as you would expect, done in 9 UK hospitals so far. Now, normally in clinical trials, entry to these groups should be fully randomised. But because this was a small-scale study, that wasn't done. So there were some things that weren't randomised. So, for example, in the treatment group, there turned out to be more diabetics. And there turned out to be more people with heart disease let's see. No, there's more diabetics. The treatment group had... I think that might... Just ignore that one. That one might be wrong. I think I might have got the figures the wrong way around in that. But anyway, in the diabetic group... there was 9 diabetics in the treatment group and 3 diabetics in the placebo group. But of course, diabetes is a big risk factor, so this doesn't detract from the results in any way. But the whole point about a randomised controlled trial is that entry to each group has to be randomised, so we're comparing like with like. I think actually from memory that this was the other way around. I think in the treatment group there was 8 people with heart disease and 5 people in the placebo group. Anyway, it doesn't matter. It just shows it wasn't fully randomised. Could that influence the results? Yes, it could. But here, that would tend to mean that the result was stronger than it actually was, because diabetes is associated with a poor prognosis, and there was more diabetics in the treatment group than in the control group. But this is the whole point about clinical trials. We shouldn't try and work it out. It should be randomised. Anyway, now recruiting patients who are acutely ill in the community, which is also good, so they're expanding that. Now, the results. 79% reduced risk of developing severe disease requiring ventilation or resulting in death in the treatment group. Impressive. They did 79% better. During the treatment period, which was 16 days, but differences were also noticed after 28 days. So how big the differences were after 28 days, we don't know, but definitely after 16 days they give us that data, and 79%. Impressive. Patients are 79% less likely to develop severe complications requiring ventilation, and they're less likely to die. Patients who received the beta interferon, this is the experimental name for it, were more than twice as likely to recover. Pretty good, twice as likely to recover. And that's defined as no limitations of activities or no clinical virological evidence of infection. In other words, they became antigen negative, also impressive. Subjective measures of breathlessness were reduced. They felt less breathless as well. So all good stuff. Patients with more severe disease at the time of admission. Now, this is the other thing about this. It seems to benefit people at every stage of the illness. So it seems to benefit people at an early stage, seems to benefit people at a later stage. So that's good. So this could be given to someone who was critically ill and in danger of death, or it could be given to someone who's very mildly ill, who we want to prevent deterioration in. So increase the likelihood of hospital discharge during the study. They're more likely to be discharged. And the difference there was 6 days versus 9 days. So if they had the active treatment, they were discharged in an average of 6 days. If they're in the placebo group, they're discharged in an average of 9 days. Now, because the numbers weren't large enough, it's not possible to say that was a significant difference. It hadn't reached the 95% confidence limits, because we have to be 95% sure. But that's probably because of the small numbers. 6 and 9 are a big difference. So if we had a few thousand patients in that, and we got the same result, that would be massively significant. Patients more than twice as likely to have recovered by the end of the treatment period. Strong trend, again, not significant because of the small numbers. But again, if that was replicated with larger numbers, that would be massively significant. Now, what about safety? Because phase 2 clinical trials are largely to evaluate safety. Well, in the placebo group, 6% died. 6% died in the placebo group. No one died in the group receiving beta interferon. Remarkably promising. This appears to be safe. This appears to be a safe drug. Professor Tom Wilkinson, who is the clinical lead, Professor of Respiratory Medicine, University of Southampton, Chief Trial Investigator, he says it has huge potential to be able to restore the lung's immune response. So the lung is supposed to respond by producing the interferon, but this rascal virus stops it from responding, and this is putting back the natural response that the virus has taken away. It's clever, it's good. Giving, according to the professor, according to Tom Wilkinson, giving enhanced protection, accelerated recovery, countering the impact of SARS coronavirus 2. So it is countering the interferon inhibiting effect of coronavirus 2 by restoring the levels of interferon. Professor Stephen Holgate from Medical Research Council, clinical professor of immunopharmacology at the University of Southampton. He said it restores the lung's ability to neutralise the virus. Interesting. So the lungs, if it was allowed to go on producing its own interferon, could neutralise this virus because the virus stops the production of the interferon. It can't do that. And this drug restores the lung's natural ability to fight the virus. Now, this is very interesting. Or any mutations of the virus. So this interferon response, the interferon release, is generic. It'll work against a wide range of viral infections. So if this virus was to mutate, it doesn't seem to be mutating much, but if it was, then by enhancing this effect, this interferon effect, interfering with the ability of the adjacent cells to produce more viral particles, it works against any virus. So that is remarkably promising. So a lot of drugs, if the virus mutates, the drug no longer works. But this is bolstering the body's immune system by bolstering its interferon mechanisms. Therefore, mutations in the virus become irrelevant. Or co-infection with another respiratory virus such as influenza. So this is going to be so important for the next influenza season. So in a few months' time, when winter starts again, there's going to be influenza and COVID-19. Now, part of the reason it's so dangerous to have influenza and COVID-19 is because the COVID-19 switches off the interferon mechanisms, which inhibits the spread of the COVID-19 virus and inhibits the spread of the influenza virus. But now, if we give back the interferon, then that's going to restore the lung's ability to fight the COVID-19 and restore the lung's ability to fight the influenza. Therefore, I would expect that to greatly reduce the case fatality rate in patients that got COVID-19 and influenza at the same time. So we now see in retrospect that part of the reason it is so dangerous for people to have influenza and COVID-19 is that the COVID-19 basically turns down or down-regulates the interferon mechanism, and that allows the influenza virus to run riot with no interferon suppression, meaning the influenza is much exacerbated. So this is going to be massively helpful. We would assume, we don't know this because we haven't got clinical trial data, but it makes perfect sense. This will be massively helpful, indeed probably life-saving in many patients who were unfortunate enough to have COVID-19 and influenza at the same time. Now, the other two drugs, and there are only two other drugs of proved efficacy so far, are dexamethasone and remdesivir. These are the only two other drugs we know works. These are the only other two drugs we have clinical data on. Now, first of all, the dexamethasone. The study did not include patients requiring ventilatory support. So remember, the dexamethasone was only given to patients requiring oxygen or requiring CPAP, positive pressure ventilation, or people that were ventilated. And this is not the group that was given to. So no overlap there. Remdesivir wasn't specifically mentioned, but remdesivir just seems to make recovery quicker and doesn't seem to affect overall case fatality rates. Whereas we know the dexamethasone means that less people will die. And it now looks quite strongly that the interferon, the inhaled beta interferon, will mean that less people will die as well. So where does that leave us? It means we are absolutely desperate for phase 3 clinical trials involving thousands of patients. And I would hope this would be rolled out now into an international trial, and it would go where there's lots of patients suffering acute illness now, like in Brazil or like in India or indeed the United States, so that there's plenty of patients that can be given this. Now, you might ask about the efficacy of this. How ethical is it? Well, at the moment, the people in Brazil, for example, that are getting COVID-19, they're not getting this. So if they enter the trial, there's a 50% chance they'll get salty water, which is the placebo. But there's a 50% chance they'll get the active treatment. Now, the placebo won't do them any harm, but the active treatment could save their lives. So if someone said to me, you know, I've got a new treatment here, it's absolutely brilliant. And I tell you what, there's a 50% chance you're going to get it. Would you want it? So would I want a treatment? Would I want a 50% chance of a treatment that could well save my life? You bet I would. So and at the same time, we can collect the data as well. Tragically, it does mean that some people whose lives could have been saved will get the placebo. That's what needs done now. Massive international clinical trials in areas where there's a lot of COVID-19 prevalent, and this is remarkably promising. So that's what I want to say about that. I just will say something though before I finish about this clinical trial idea, and it is difficult. So I worked on coronary care when we started the first trials into streptokinase, which was the first clot-busting drug. That was the first one we used. And after we'd been given it for a few months, we could tell by the side effects on the patient whether they were getting the placebo or whether they were getting the streptokinase. You could just tell. It was just, there was a few clinical indicators. And one day, a patient came in who really would have benefited from the streptokinase. He had the particular type of clot in the particular place that would have really benefited from the streptokinase, or we thought, because we didn't know then, because we didn't have the trial data. And we gave him the bag out of the trial tub, and I knew when I was giving it that it was the placebo, so that was really quite hard. But because the drug wasn't available then, all I could have done was given him another one, and then he would have another 50-50 chance. But of course, I didn't know that for sure. It could have been that I was giving him the streptokinase, but clinically I was fairly sure that I wasn't. So it is difficult, but personally, all I can say is, suffice it to say, personally, if someone said to me, if I was sick with COVID-19, would you like to go in this trial? There's a 50% chance you'll get the active treatment. I would say, yes, please. Absolutely, yes, please. That's what I would be my personal response, or indeed for any member of my family that I was responsible for. A 50% chance of an efficacious treatment is better than a no% chance of an efficacious treatment.